What I want to talk to you about is some stuff that you've been hearing all day, some stuff that you'll hear in your professional work, in your education, the mechanisms underlying treatment. So the rationale that people attempt to explain to you as to why you do what you do, why you make choices. There are major issues with almost all of these mechanisms. When you are considering anything that is outside of your environment of observation, you have a problem. So in hands-on therapy, the environment of observation is outside the patient. So you can only observe things outside the patient. That said, you can attempt to infer information from outside the patient as to what's going on inside, but you are definitely making an assumption. So many of you may have heard the old dad joke, don't assume because you'll make an ass out of you and me. Well, that lets me talk to you about the principle of parsimony. All right, so it doesn't quite rhyme, but it's close. The principle of parsimony is essentially the manner in which you will interpret your data in a scientific sense, whereby the explanation that provides the most predictive power, or the most explains the most rather, while assuming the least, is probably the most useful or most correct one. Now, if you get new data, you may actually be able in the future to assume less, explain more, something along those lines. So if we take the principle of parsimony, then you have how much you assume versus how much you explain. Well, if you have an explanation that or in future you have new data and you're able to assume the same amount and explain more, that's better. If you're able to explain the same amount and assume less, that's also better, or if they both happen, that's even better. Now, if you're talking about a mechanism, if you're talking about proprioception, if you're talking about muscle spindles, if you're talking about the GTO, if you're talking about being able to identify what the heck an organ is doing based on movement, you're making huge assumptions. If you talk about movement that's observable, you're making almost no assumptions, because anybody, the patient included, can identify it. They can see it, they can observe it. Anybody outside the patient can also observe it. So when you're considering why you do what you do, regardless of your actual hands-on profession, what you're doing is you're identifying what kind of motion there is, so how restricted or how free it is. Then you're going to have to intervene with it, and then you're going to have to reassess it. Now, when you reassess it, you cannot reassess a different way. So one of the things that you will observe when you're watching many practitioners, they will assess one way and reassess another, and they'll tell you it's different. That's not okay. So you want to assume as little as possible. So in how you assess and in how you reassess, if you reassess differently, you're assuming, right? So you want to minimize your assumption set. You go from identifying the movement restriction, intervening with it in a predictable way, and getting a stable range of results based on your reassessment that's the same as your initial assessment. No mechanism is required to explain that. Only observation in the appropriate environment, which is outside of the patient. You need no mechanism. If you assume mechanism before you have a stable phenomenon, before you can really identify the movement, consistently intervene with it, and consistently get change on the same test, there's no point in looking for a mechanism. It isn't worth your time, because you can't even control the phenomenon. You can't even work on it. So what you're getting often in most manual therapy education is really cultural transmission. So your instructor learned it a particular way with a particular story associated with it. They teach you that, or they go out and find a different one that they like better and they teach you that. But if it's explaining anything inside the body, it's assuming. Now, many people will point to mechanistic research where it's like, oh, well, when we do this thing happens. Mechanistic research, you might be able to find a mechanism that works here, but when you look at the general outcome in a living human, if it's not stable or isn't consistent with the mechanism, then it's not the right explanation. So if you look at a system like craniosacral or cranial osteopathy in the cranial field, cranial osteopathy, in chiropractic, they have craniopathy, anything like that. If they want to talk to you about cerebrospinous fluid, and you think that everything that you're doing is because you're palpating the cerebrospinous fluid and you're changing the cerebrospinous fluid, you're just flat out wrong, right? There's nothing to your ability to actually observe and interface with that. It doesn't mean that there isn't a stable phenomenon. It does mean that the cerebrospinous fluid is a low pressure system. You're not going to palpate it through a wet occiput, basically like a wet. Have you seen a wet bone versus a dry bone? They're very different. A wet bone is much thicker. Also, most people, when they palpate in the region of the occiput, they think they're fully on the occiput, and they forget that there's a huge amount of muscle going to the superior nuchal line, so almost all of the occiput is covered. So just at superficial sniff, anything with respect to palpating cerebrospinous fluid or the primary respiratory mechanism, based on the claim that people are making and what they're feeling, they're not even in the right place, right? So if you scratch at a lot of these mechanistic explanations, they have no feet to stand on. So the principle of parsimony suggests we need to assume as little as possible and explain as much as possible. If you stay on movement, you can do that. Anytime you go inside the body with your thinking, you're assuming more and explaining less. So it violates that. Now, it doesn't mean that everybody has to like science. It doesn't mean that everybody has to work that way. But it does mean for your ability to control what you're doing, minimizing very heavily anything that you're talking about that's inside the patient, that you explain to the patient, or that even you think is going to help you. Now, there's another thing that you want to consider, which is called cognitive load. There's 3 types of cognitive load. There's the intrinsic load, so just how complicated something is. So the more interacting elements, the more complicated it is, the harder it is to think about. I think most of us would agree that that is the human body, right? Physiology has a lot of interactive elements. You're not going to be able to think about it appropriately to be able to interface it with it. Because if you start doing that, you won't pay attention to your hands, you won't pay attention to your eyes, and you won't pay attention to your ears. You're in here. So you have a problem there. There's the extrinsic load, or how complicated the explanation of something is. So if somebody really took you down the rabbit hole of physiology and that's how you think, it's very complicated. If you're thinking a lot, you're not paying attention to the patient. There's the germane load. So how complicated a topic actually is, has a certain processing amount that's required, or like sort of a mental horsepower. The more mental horsepower you need, the harder it is to think about it. The more you're paying attention to your thoughts, the less you're paying attention to your patient, right? So we have the external environment of observation. You're outside the patient. Anytime you try to go inside the patient as far as your explanation, your thinking is concerned, or your rationale, you're violating the principle of parsimony. And you want to manage your cognitive load. If you stay outside, if you identify a movement problem, whether it looks like this, whether it is yield to pressure for soft tissues, either way, you're going to be able to consistently find motion restrictions. If you interface with those and you change them using the same test, then you know that it changed. You can't shortchange the test. You can't lie about the test. You've actually got to do the test properly. But if you're consistent with that, you're respecting the environment that you're in, outside the patient's body, you're not violating the principle of parsimony, and you're managing your cognitive load, right? Consider a full clinical day where all you're doing is thinking about physiology. You're probably not paying attention to the patient. So, if you're thinking about the mechanisms, you're probably further away from what you should do than you could be. There is actually a paper that just came out in the International Journal of Osteopathic Medicine. What it did was it took 3 rates. So there's this thing called the primary respiratory mechanism. It's in cranial osteopathy. It's the breath of life, so it's a pulsation at a particular rate. It's said to be, I believe, 8 to 13 times a second, which is right with thoracic respiration, but they say it's not thoracic respiration, so they're wrong. But anyways, what they do is they had patients, or students rather, assess the primary respiratory mechanism, and they would report the rate. The rate was all over the place. Didn't matter on the student, it was all over the place. It was very inconsistent. Then they told different groups of students that it was a particular rate. That was the normal rate. So they gave them an anchor to look for. And guess what? All the students reported the rate they were taught. So if you see something like that, so one of the things that the paper concluded is that depending on how you teach something, it will impact how people interpret it and how they utilize it. Their conclusion was that if you teach them on the mechanistic level, they probably don't pay attention to their hands, which I think is actually the most accurate way to consider what they found. The more thinking that you do inside the patient, the less you're paying attention to what you can pay attention to. So again, there's a lot of redundancy in what I'm saying, but you're outside the patient, assume as little as possible while explaining as much as possible, and manage your cognitive load. That is, in essence, why the mechanism doesn't matter. If you are driven by the idea of the mechanism, you're not paying proper attention to the patient, you'll miss a lot, and you will essentially overlay or bully your worldview onto the patient's body, even though you can observe that it's not doing what you want it to do. So if you respect the environment that you're working in outside the patient's body, and you don't worry about the mechanism, you pay attention to the patient, you'll almost always find the right solution. It's a lot of times, it's a little bit of this and a little bit of that. People will teach you one way, so you can be stuck on the details that you're taught as far as technical stuff is concerned. But if they teach you a way to search for what to do with that patient, and almost all practitioners will do this as they move from novice to expert, it's a little bit of this and a little bit of that. It's a little bit of this and a little bit of that. No one system can do it all. Ligamentous articular strain can't do it all. Cranial can't do it all. Visceral can't do it all. Lymphatic can't do it all. Fascial can't do it all. None of it. If you pay attention to the person on the table and you're honest, you will find a little this and a little that. If you have a way to consider how to work through figuring out what does it, you'll be even better. So if you're explicit about that and you have a search strategy, as opposed to, I found this problem, this is what I do, you'll probably get it right more often than not, right? If you search for what to do. The only way to, well, not the only way, but the most likely way to start that is don't think about what's inside, just think about the movement. The mechanism really doesn't matter. If, again, you make assumptions, this is from the Fresh Prince, you look like an ass and the ump will shun you. Or if you assume, you make an ass out of you and me. So don't do it, because you're not paying attention to the real live person who's there. You are beating your personal worldview and preference onto them. Don't do that. The mechanism is not the answer. Even if, as we go forward in the scientific method, we're able to gather more data and figure out what the mechanism is, it doesn't matter. Because the way that you have to report it, you have to get a wide range of data. And you have to normalize that to report the range in which you should find stuff. When they report the range, they have to also acknowledge, or anybody who's reading it has to know, that there's outliers. There's people way to the left and way to the right on whatever plot you've got. They are the people that show up. The normalized data never shows up, right? So I am a person, I call myself a man of science because I have an MSc. So I actually did a thesis experiment. I know what that process is. Because I know what that process is, I can more strongly tell you the mechanistic research will never, ever tell you how to treat the person in front of you. They'll never tell you how to interact with them. They can give you a nice range to start from, but you've got to go left, you've got to go right. It's a little bit of this and a little bit of that. So the mechanisms are nice if you feel like, if you want to feel smart, like, haha, look how smart I feel. But that doesn't help your patient. What's going to help your patient is paying attention to them, looking for movement problems, working on those with a stable range of approaches, and whichever one works the best, you'll figure it out really quickly. That's the one you'll use. So that is why the mechanism doesn't matter. So thank you very much.